Today we have with us Dr. Somrita Ganchoudhuri, and she will be talking about communication negotiations among civil societies for HIV/AIDS in India. Dr. Somrita Ganchoudhuri is a freelance research consultant with organizations such as SingHealth and is based in Singapore. She is an alumna of the Department of Communication, University of Hyderabad, and completed her PhD at the National University of Singapore. Her talk is based on her doctoral thesis work. Hello, Somrita. Welcome. Over to you, please.
Thank you. Thank you, Davina, for giving such a good introduction. Hello, everyone. Thank you so much for participating today in this online research roundtable session. I'd like to first thank the organizing committee and the esteemed faculty for hosting this event, and it gives me immense pleasure to be back here at HCU, my alma mater, which shaped me for my PhD. And today in this talk, I'm going to talk about my PhD dissertation. I graduated last year of July. So my PhD dissertation, the title is Communication Negotiations Among Civil Societies for HIV and AIDS in India, a culture-centered approach. Today's agenda, I'm going to give you a brief overview of my thesis and then show you some of the location maps and fieldwork pictures, followed by the question and answer session. So I did my PhD study. I studied National HIV and AIDS program in the context of Nagaland. So just to give you a brief background of HIV and AIDS in Nagaland, it was around 1990 when HIV virus was first detected in Nagaland. And at present, Nagaland is one of the top 3 states with high HIV prevalence rate. So since the 1990s, Nagaland's health landscape, HIV health landscape has gone through various waves of transformation. However, once upon a time, there were a lot of stigma and discrimination, which is of course lessened over the period of time. But earlier community members were detected of HIV, HIV were detected positive, they were excommunicated from the villages. There was also a time when people were also put in cages in the centers of the villages, people who were tested positive. So that was long time back ago when human rights organizations did not reach Nagaland, and so things like this were being practiced. So now moving on to my So just to give you now a brief overview of my thesis. So my thesis is situated in the context of neoliberalism. I looked at the neoliberal transformation of health landscape broadly under HIV and AIDS landscape specifically. So neoliberalism, as defined by scholars such as David Harvey, is a process of economic organizing that operates under the assumption that human development is best achieved through liberation of individual entrepreneurial freedoms such as free market and free trade. Human health is one of the primary spheres that has been severely impacted by neoliberalism. So under neoliberalism, the concept of health is constructed on market-driven economics. With globalization, the neoliberal logic of health demonstrates health as a private and individual responsibility that can be best achieved through privatization of healthcare or through technological advancements. And as a result, we have also witnessed a weakening of public health programs. However, in the context of India, the neoliberal trope of health doesn't seem to fit, because in India, where poverty is often considered as one of the primary reasons of disease and illnesses. So meta-theoretically, my dissertation interrogates the ways in which NGOs interpret and negotiate neoliberalism while working with the margins, and how then they become contingent spaces in that negotiation. So I looked at how NGOs as mediating spaces negotiate the state, the private sector, large foundations such as Gates Foundations, and the margins, and how it also becomes contingent spaces of such kind of negotiations. So in doing that for my dissertation, I compared 5 NGOs. Four of them are run by the civil society, and one of them is a community-run NGO. I use the culture-centered approach as a meta-theoretical framework, that is culture-centered approach, CCA. And within this meta-theoretical framework, there lies the interplay of culture, structure, and agency, three key tenets, which then enables me to ask the question that how do NGOs situated within the context of India's Northeast, displaced from the mainstream centers of India, construct the HIV and AIDS provision while working at the margins. So now to give you a brief overview of the context, CCA, the culture-centered approach, highlights that to understand health, we need to understand the cultural and structural conditions within which health behavior occurs. So I conducted my study in Nagaland. You can see that I have pinpointed it. Nagaland, like the rest of the northeastern parts of India, Nagaland, like the rest of the northeast part of India, exists in physical isolation from the rest of the India. And it is also unique. It has a unique status due to Article 371A, guaranteed by the Indian Constitution, that protects the Naga tribe and Nagaland from the intervention of Union government and its policies. So I conducted my study. On the right-hand side, I have given the photo of the map of Nagaland. I conducted my study in Dimapur and in Kohima. Dimapur is the financial hub of Nagaland, and Kohima is the capital of Nagaland. Now, when we look back at the political history of Nagaland, Nagaland has a decade-long armed struggle since 1950s due to the separatist movement, due to their demand for a sovereign Naga state referred as Nagaland. And since 1997, there is a ceasefire agreement between the Indian government and the separatist groups in Nagaland. So this separatist movement and this political tension in the state has led to a lot of political instability and bloodshed in the state. The social fabric of Nagaland is fundamentally different from the rest of India because of its linguistically, culturally, and ethnically distinct uniqueness. And some of the social structures that shape the lived experiences of the people of Nagaland are the separatist groups, which are also referred as the underground or the parallel government. And second is a church, Nagaland Baptist Church Council. Then in Nagaland, other social structures are the village leaders or the colony leaders, also referred as Kwanbura, and the customary laws. So in Nagaland, each village, which is of each tribe, has its own customary laws. So these are the social structures that impacts the lived experiences of the community members, even the community members who are at risk of HIV. So I looked at the implementation of National AIDS Control Program, which is designed by National AIDS Control Organization. National AIDS Control Organization is the nodal organization of India that works towards the implementation of this program throughout the country. Under National AIDS Control Organization, we have state AIDS control societies. So in each state, there is one state AIDS control society, which will work in collaboration with the NGOs, which then implements the National AIDS Control Program and work with the community members. So this whole program is funded by the Ministry of, like 63% of it is funded by the government, by the Ministry of Health, and the NGOs ensure that they implement this program among the community members. Just to give a very brief overview of the theoretical framework that I used for this study, that's culture-centered approach, CCA. So CCA has three key tenets. CCA draws from the subaltern theory and the post-colonial theory. The three key tenets are culture, structure, and agency. So you have to we examine the interplay of culture, structure, and agency to understand the meanings of health and the communication strategies and tactics that are needed for better health communication. Here, culture refers to the local context within which health meanings are constructed, such as a community's set beliefs or attitudes or meaning making of a disease. Structure refers to the aspects of social organizations that enables or that restricts one's access to structural resources such as hospitals or good transportation system. Agency then refers to the community members, the cultural members' capacity to enact and participate in this negotiation process. So I used culture-centered approach to do this study of mine. The research questions that I asked to understand the communication negotiations are the meanings of HIV and AIDS in Nagaland, the local context that influence HIV and AIDS in Nagaland, and the various challenges that the NGOs face while implementing this national program, while communicating about this program. So methodology, I studied 5 NGOs. I did in-depth interviews with 56 participants. I spent few months in both Dimapur and Kohima to study the targeted intervention programs, that program that is designed for the community, injecting and drug users community, female sex workers community, migrants, and truckers. So I worked with the NGOs who work with this community members. So when we look at the HIV and AIDS program, there are 2 sets of groups who are at risk of HIV. One set is called as high-risk groups, and IDUs, FSWs, and men who have sex with men, transgenders, and hijras, they come under this category of high-risk groups. And then we have migrants and truckers, who are referred as the bridge population because they are considered as the one who connects this high-risk group and the general population. So I studied, I conducted my interviews, participant observations at all these field sites, office sites, where they're working with the community members. So in today's presentation, I thought of just highlighting the challenges that the communities face while communicating with these at-risk groups, with the community members. And as highlighted by the NGO actors, and some of the challenges that they face while communicating about HIV and AIDS program include lack of trust, access to the field, financial insecurity, health infrastructure, outreach work, community participation, and empowerment. So, for example, lack of trust is usually mentioned in regards to National AIDS Control Organization's guidelines. So, according to NACO's guidelines, each community member, each member from the high-risk group is supposed to get tested twice in a year. So each NGO has 600 to 700 members, and throughout the year they have to ensure that the registered members are going for the blood test twice in a year to make sure that they are HIV negative, and in case they are positive, then they are referred for further treatment. So when I was spending time during my field work, I observed that most of the month is then geared towards it. It's about communicating to them about the blood test and the dates for the blood test. And there is mutual disagreement among the community for this blood test, and that's what results in lack of trust among the community members and the NGO. So usually the problem occurs during the second time blood test when they are already tested HIV negative for the first time. And the NGO actors often they will face accusations such as stealing of blood, especially from the members who have been registered with the NGOs for more than 10 years. So for more than 10 years. And this kind of unhappiness and disagreement is mostly among this community, because they keep saying that for the past 10 years they are getting tested and there is no need for it. So the NGOs then have to negotiate such kind of challenges, because each NGO has a target to reach every month and for the whole year. So these NGOs are funded by NACO, hence their functioning is strictly linked to the NGO guidelines, and they have to ensure that they reach those targets. So the HIV/AIDS program of India is based on a business model where the effectiveness of the NGOs is evaluated based on the targets that they reach. So based on the targets that they reach, the analysis hence is done on a very done following a very quantitative format. So while doing my field work, I came to know from like most of the NGOs, they expressed their unhappiness with this quantitative format. So when we think about CCA, culture-centered approach, it highlights that to understand one's health, we have to examine the structural impediments within which health behavior occurs. For example, whether one has access to the health resources. And with this kind of quantitative data format, what remains absent from the dominant discourse in the discursive space are the cultural and structural factors that actually shape their lived experience. Hence, it becomes a challenge while implementing this program. Then again, if we look at some of the other challenges, for example, health infrastructure. So when we look at the northeastern part of India, most of the health infrastructure is quite poor. So in the context of Nagaland, there are instances when one has to walk for 4 or 5 hours just to reach a service center to get their blood test done. But such structural challenges, they never become a part of the dominant discourse, because of the linear narrative of health, which defines health as an individual and private responsibility, and the cultural and structural factors are not taken into consideration. The NGOs, they have also done advocacy work for bringing good health infrastructure in the state. So, for example, one of the directors shared with me that the story of how they got second-line ART treatment to Nagaland. ART treatment is antiretroviral treatment, and it is available in 3 phases: first line of ART, second line of ART, and then third line of ART. So, in case of Nagaland, it's ironical that Nagaland had had a high HIV prevalence rate for such a long time, but still only first line of ART was made available in the state. So the NGOs actually formed an advocacy board, and they conducted meetings with NACO to finally bring this health infrastructure. So they posed resistance, and it finally brought this health infrastructure in the state. So these are some of the challenges, and I'd be more than happy to discuss more in depth about some of the challenges in the Q&A session. Now moving on to my main theoretical finding. So my key findings are that the space in which the NGOs function, it is a dialectic space. where the NGOs then negotiate various dialectics, various power differentials. On one hand, they give into this neoliberal project, neoliberal framework, and are negotiated. On the other hand, they also pose resistance. They also become creative sites of resistance. So now moving on to some of the fieldwork pictures, that's how a typical office space looks like in Nagaland. These are taken with some of the NGO actors who have been implementing this targeted intervention program. And the NGOs that I worked with, all of them have been in this field for more than 10 years, some of them like 15 years. This is again some of the pictures from the fieldwork. This is, for example, I worked with the Migrants and Truckers project, where here you can see body mapping tools. So it is one of the tools that they use to communicate about the various risks that are associated with this disease and how one can, how the virus gets transmitted. And these are some of the pictures of DIC in Kohima. DIC refers to drop-in centers where the community members go to get the services that are given under the HIV and AIDS program, NSCP. So just to summarize, this project, I sought to explore ways in which dialectics are negotiated, and what my dissertation demonstrated that any creation or any creative site, any creation of space at an NGO level is both a space of negotiation and resistance, as well as co-optation into the neoliberal framework. So I will end my presentation with one of the quotes by one of the participants, Shritio. He is one of the outreach workers with this NGO. So he tells that my aim is to take care of our community as much as possible. Our first problem is drug use, and HIV is secondary in today's scenario. But since we follow NACO, therefore HIV prevention is seen as the main problem. So this quote actually captures the essence of the dissertation. It talks about the differentials of power that exist between the donors and among the NGOs, the donors. When I'm saying donors, I'm talking about National AIDS Control Organization or State AIDS Control Society. And then the power differentials that exist among the NGOs and the community members who are at risk of HIV. I'm referring to the high-risk groups and the bridge population. This is, I have come to the end of the presentation. This is another picture that I took here during my field work. Nagaland is a beautiful place, and that's all. I hope I am within time.
Yes, you actually finished 5 minutes early, so that's great. You can stop sharing the screen now so that we can have that bandwidth available. Okay, great. Thank you.
Yes.
Thank you so much. Your presentation mapped out challenges NGOs face as culture, structure, and agency interact while communication negotiations happen. NGOs have to serve donors like NACO in this case, and also listen to the community, which I think is an important lesson in sort of judging balancing these two and judging which way to lean on for people interested in communication for development. We will now have live questions from the Zoom meeting participants in a bit. And Somrita, I will ask you all the Zoom chat and FB live comment questions towards the end of the meeting. I request participants to raise their hands, and I will announce your names in order. You will find the raise hand option next to your username. If you can't raise your hand, please let me know that you would like to ask the question via personal message here in chat. Kindly turn on your microphone and or video depending on your connection when it is your turn to ask. Please keep your questions as brief as possible so we can have maximum interaction with the speaker. We will take questions starting now for the next 15 minutes only to manage time better. Okay, so we have a few chat questions already actually. So I think I'll flip the order there. Let me just also post the question in chat for everyone to see. So this was actually an earlier question from Facebook Live. I've just posted it here for everyone to see in chat. So they're asking, what did you mean by the physical isolation of Nagaland when you were describing the geography?
Yes. Yeah, by physical isolation, I'm referring to the geographical isolation. Like the rest of the Northeast India, Nagaland also exists in physical isolation from the rest of the India, and it is connected with a very small corridor, which is referred as the chicken's neck corridor. So that's what I meant by physical isolation.
Right. Another question that we have is from Hazina, who's a PhD student at the department. She's asking if you observed any difference between discursive spaces offered by NGOs run by the community themselves versus NGOs which are run by people coming from outside. And she's assuming that you've worked with both of them.
So I'll just like to add to the first question, Asen's question, and the reason why I mentioned about physical isolation, because it kind of determines the structural factors that are available in the state. For example, when we look at the northeastern states, because of physical isolation, we see lack of investment of private companies there. We see a lack of good health infrastructure. So that's why I mentioned about the physical isolation. And that's why it is very important when we talk about structural factors or when we talk about contextualizing a research problem, contextualizing health. Now, moving to Hazina's question, have you observed any difference between discursive space offered by an NGO run by a community and by outsiders? Yes, definitely. So when I compared these NGOs, the NGOs run by civil society and the NGO run by the community, one thing is common, that they both have to follow the guidelines that are given by NACO. But the difference with the community-run NGO is that the awareness of the NGO actors, it is much more than the awareness that we see in the civil society organizations. For the quote that I added at the end of my presentation, where Shitio, the outreach worker, he is very much aware that because of this homogeneous model of NACO, they have to follow something which sometimes doesn't fit the context or which sometimes poses extra challenge. So such kind of awareness of the problems is more evident in the community-run NGO. And the NGO members, they sort of put it out in their narratives that it's because of the donors that they have to follow certain guidelines, even if sometimes it does not make sense in that context.
Yeah, I mean, I actually was, when we were talking about the quote, was wondering that the priorities have changed. But because donors come from a certain, in this case, it's like a government bureaucracy where a target has been set, and it's difficult to change that because we are probably not listening to the community as much as we need to.
Yes.
So focusing on drugs versus focusing on HIV, for instance.
Yes, like most of the IDUs, the community that works with injecting drug users, they kept talking about that how this OST program, it's a harm reduction program. So they are dependent on OST. So it's not a total abstinence. but they are given this OST because OST is it's considered to be one of the most effective components of this HIV and AIDS program, because if they are not injecting drugs and they are taking OST, then the risk of getting HIV is lessened, whereas the community still continues to be dependent on this legal drugs. So yeah, some of the ITU communities, they were saying that it would be better if there was total abstinence program, but since they have followed the certain guidelines, they have to work according to it, and in that process they get negotiated. Yeah. Okay, there is a
Yes, we have another question from Professor Kanchan Malik from the department.
yeah.
And yeah, she's asking about how difficult it is for people to walk into a DIC.
Okay. Is there a stigma attached to be accessing any services offered, and how do NGOs deal with this? That's an excellent question, ma'am. Yeah, definitely there is a lot of stigma associated with even visiting the NGOs. I'll give you an example of one NGO in which they are working with female injecting drug users. So the drop-in center is actually located in the market. And when I was interviewing with the NGO workers, I came to know that a lot of times this female injecting drug users, they are very hesitant of visiting the drop-in center. So here we have to understand that it's a very small place. So when we are talking about Nagaland, it's a very small place and it's a very closely knit community. People know each other, and the drop-in centers are usually located in your locality, and the community members are asked to register in the drop-in center that is in their locality. Hence, if someone is visiting to the drop-in center, there is always a possibility that your neighbor might come to know about your drug use. So that becomes a very big challenge, and there is a lot of stigma, because one of the dominant discourses that I came to know is that HIV is often labeled as a disease of the sinners, because there is so much of stigma and discrimination with the communities who are at high risk. And how do NGOs deal with this? So in many cases, the NGOs they try to come up with an alternative narrative of HIV, and they try to communicate even to the greater society that HIV is just like any other disease. In fact, and they'll say, in fact, it's better than diabetes. If you are taking antiretroviral treatment, then you are fine. You can do your work. So they really work towards the stigma and discrimination that the communities face, but it is still there, and hence it can never be told if we are able to reach all the community members, because stigma and discrimination is one of the practical challenges that people follow, especially when they are in a smaller place where people know each other. Thank you.
Oh, so there's an interesting comment from the person who asked the first question. I'm just posting it for everyone on chat here because this was posted on Facebook Live. She's happy to know that you've done your PhD on a topic that's similar to the topic that they've done it on, and they've congratulated you. And I actually wanted to ask you this question regarding isolation and ART. So you mentioned that you only have the first round of ART treatments available in Nagaland right now. Does that have to directly do with the isolation of the state, or there are other factors as well?
I'm sorry, what does that have to? I didn't understand the last.
Does that have to do with the isolation of the state, the physical isolation?
Okay. So
the delay
for
in bringing treatments?
yes. So for example, for first line of ART, second line of ART, and then third line of ART. So first line of ART is the first treatment that one gets. And then when the CD4 counts goes up, then they go for the second line of ART. So initially, Nagaland did not have that infrastructure, because according to NACO, they needed certain infrastructures to make it available. However, after a lot of advocacy, that changed, and now they have second line of ART in the state. But third line of ART is still missing, because according to the guidelines, third line of ART can be available in a place which has a medical college, which means they will have better infrastructure. So it is again linked to the isolation, the physical isolation, and the kind of development that has happened in the state. And when we look at the development of the state, it's quite low compared to the other northeastern states. So yes, it is definitely linked to the physical isolation and good health infrastructure.
We have a few live questions on Zoom here. Vinod sir, if you can hear me, please unmute yourself, and if you can also turn on your video, depending on your connection. Yes.
Somrita, thanks for that presentation. I have two short questions. One is to do with your idea about the dialectic space that you said NGOs seem to be occupying. Could you elaborate on that a little bit more, maybe with some examples? And the second question I have is to do with this important third leg of the CCA model, which is agency. I haven't heard that much about agency coming out in your presentation, especially in the context of behavior change modification kind of a model that NACO and other HIV/AIDS agencies adopt. What kind of agency can the so-called targeted population exercise? What kind of negotiations do they have to make with their agency? Yeah, these are my two questions.
Yeah, sure. Thanks, sir, for this question. So when I'm referring to that this space is a dialectical space, when we look at how the NGOs function, so as I said, on one hand, they give into this neoliberal framework. For example, they have to follow this guidelines, they have to follow this quantitative format. And most of the NGO workers, they raise their concern about this quantitative format, because then we will not get to know about the other structural conditions or cultural conditions that these community members have to face. But they have to follow these guidelines, and that's where they get negotiated, and it's because they have to follow the guidelines that is given by the donors. And if they don't follow the guidelines, if they are unable to reach their targets, or if they are unable to give the reports that are required for the continuation of this project, this will result in they losing the project. So even if they are aware of the problems, they still have to get negotiated according to the guidelines that are available. But they also act as sites of resistance. And that's why I said that on one hand, they get negotiated, they get co-opted, but on other hand, they also become creative sites of resistance. In this case, we can take the example of how they advocated for second line of ART treatment and how they got it in the state. So it's not a space which is safe which is free of any power differentials or power play that exist within this space. And when we are referring to agency, like how the community members, they enact their agency. So I'd first like to tell that I mostly looked at the agency and that the NGOs, how they enact the agency that they have. So, for example, one of the examples that I can give is that, so in Nagaland, there are no brothels, and according to the NACO guideline, the target population whom they can serve, they have to belong either to injecting drug users or female sex workers. But in Nagaland, the concept of female sex work is different, and because there is no typical brothel setting based on which we can label somebody as female sex workers, whereas on the other hand, the NGOs, they have to give the services to certain group of females who are involved in high risk behavior. So what they do to deal with this problem, that they don't use the term female sex workers, they have come up with their own term of female HRG. So because if they use the term female sex workers, none of the community members will even agree to get registered with an NGO because they don't consider themselves as a female sex worker who is in the brothel. So there are instances like this where the community enacts its agency while serving the community members.
Okay. Thank you.
Next, we have Ushama for a live question.
So actually, I think my question overlapped a bit with Vinod's, and to some extent you've answered it. But just to clarify further, I mean, you did talk about the fact that the NGOs are conscious of the sense that they occupy a neoliberal space, and much of their funding comes from organizations that are very much entrenched in the neoliberal framework. So how, in your conversations with them, how did that consciousness play out? I mean, this whole negotiation with their own role as being part of the neoliberal economy in terms of the funding, yet acting as sites of resistance within the community.
Yes.
That played out in their conversations with you? Did you find that they were hedging certain answers or framed answers in a way that fit either one or the other role? So it was left to you really to interpret whether, how that negotiation occurred.
So when I was working with these NGOs, and because these NGOs, they have played a very significant role from the very beginning of HIV and AIDS program in India, even when we did not have a set national AIDS control program. So in a way, they were very aware of the challenges that they face because of this homogeneous model that they have to follow, and they talk about it, they speak about it, but they also say that even if we speak about it, even though we have informed NACO that there are certain structural factors which hampers our program. For example, I'll just give an example, like since throughout India this program is same, the traveling allowance for each of the NGO actors, such as the outreach worker or the peer educator, is same throughout India. So now when we look at Nagaland, there are no local railway stations, there are no local buses. Then how do these NGO actors, the peer educators, how will they go for the field visit? So they face problems like this. And in certain cases, such kind of communication has given them some success rate, and like where they have changed, maybe reduced some of the targets, but mostly they are aware of it, that because they have to continue this program, and while maneuvering through these challenges, they will be able to help the community. So this actually comes up quite a lot during the discussion. And as I said, the NGO members are very much aware of the whole politics, are very much aware of the landscape in which they function, and then how they can manage both their donors and their community members.
Thank you. Next, we have Anjali ma'am. Please unmute yourself. Yes.
Yeah. Thanks, Somrita, for that lovely presentation. My question follows from both Professor Pavrala and Dr. Raman's questions. Just a very curious thing that I'd like to ask. So you mentioned that the overall society there believe that people who get HIV/AIDS are sinners, and but how does that differ from some of the behavioral change model that NGOs tend to take? I mean, there is a moralistic position there also. And do the NGOs realize that that sort of vantage point can be detrimental to their outreach work?
Yes, thanks for the question. So as I was saying, I will not say majority of the majority of them believe it as a disease of sinners, but it is one of the dominant discourses, and which has changed over the period of time. And it is definitely detrimental when they are serving the HIV and AIDS, when they are serving the community who are at risk of HIV and AIDS. And to reduce such kind of discrimination, what they usually do is in every village, they will conduct a lot of advisory board meetings. So in Nagaland, there are many villages, or there are many colonies. So they will have they will build stakeholder relationships. So when the NGOs function, they have to, they can function only if they have got support from the bigger society. So at present now, they have conducted a lot of awareness sessions, and we have seen that a lot of it has changed. So that's what helps the NGOs when they are, for example, visiting a colony, and they want to conduct something on HIV and AIDS program. And they maintain the relationship with the stakeholders in such a way that they get the approval to even conduct a program in that ways. And as I said, a lot of it has changed over the period of time, and they are now the level of stigma and discrimination has also changed.
Thank
I
you.
hope this answers your question.
Right. So that's the end of the questions that we have for today. Thank you so much, Somrita.
Thank you.